Hello, welcome to the Q&A for rare ovarian cancers. Dr. Jubilee Brown will be leading the session. Please keep your mics muted at all times and leave your comments and your questions in the chat. Dr. Jubilee Brown will be beginning this session soon.
Great. Well, thank you so much. I am so excited to be here. So first of all, I just want to thank everyone for joining. I think this is just such an incredible organization with really such a defining purpose. And thank you to each of you for your enthusiasm and your passion about such a, it's more than a subject, really. It's something that affects so many women, people who we love and care for, and probably some of us who are joining this evening. I see that we have folks from really, wow, all over the country. This is amazing. So I see somebody from my neighborhood in Rock Hill, South Carolina. I'm joining you from Charlotte, North Carolina, here at Atrium Health, Levine Cancer Institute. We have the Land of Enchantment from DC. We have from New York City, Virginia, and I'm sure we'll be joining. So again, thank you so much for joining us. Such a great community as well. So I guess without further ado, thanks for listening. I think, you know, we were talking a little bit before that ovarian cancer in general is really fairly rare in the world of cancers. But then when we slice that down into rare ovarian cancers, we're talking about things that are really important for a minority of women. And that doesn't make them less important. In fact, some would say that makes them more important to study effectively and to get the sort of the word out, the importance out, and that's of course why we're all here today. I think I'm following the lecture that I taped earlier for you all, and so I'm happy to answer any questions and really to have this sort of virtual discussion. I wish we were in person, but the good news about virtual is that we can, you know, share a lot of information even if we couldn't come together. So rare ovarian tumors, you know, it's a basket term, a bucket term. It includes so many different types of tumors, and they're different, right? So when we talk about rare ovarian cancers, I see some of y'all with interest or experience in mucinous carcinomas, in granulosa cell tumors, germ cell tumors. They're all different, right? So, and that's, I think, point number one is that when we, quote, study rare ovarian tumors, it's not one thing that we're studying. It's a whole bunch of different entities that we're studying. I think one of the sort of take-home points in terms of advocacy is that it's hard to fund or study one little sliver, but each of those slivers is important, and so that I think is why your advocacy is important. So let's get down to it. I'm going to start at the top and sort of work down here, and hopefully we'll get to everybody. So first sort of question is there, Dr. Brown, what is new or upcoming for recurrent metastatic granulosa cell tumor? So first of all, great question. And we've done a lot of work. That's actually been sort of my baby along the way of really studying as much as we can with regard to granulosa cell tumor. We know that there are different segments of granulosa cell tumor. In other words, people who present up front and are newly diagnosed with very early stage granulosa cell tumor may not need any treatment at all other than surgery, whereas somebody with an advanced stage granulosa cell tumor may benefit from not just surgery but also adjuvant chemotherapy. And one of the things we've just looked at, and in fact I just got the information to finish the manuscript back today, we did GOG 264. So this was a federally funded NRG trial. We compared the old standard, which was BEP, bleomycin, etoposide, and cisplatin, against paclitaxel and carboplatin. And the reason that this is such an important thing is that BEP we actually started using it because it seemed to work in women with germ cell tumors. Totally different area, right? Germ cell tumors are very different from granulosa cell tumors. But we tried it because the standard, nobody knew what to do with it back in the 70s. And so we started using platinum. Then Dave Gershenson looked at BEP in patients with advanced or recurrent granulosa cell tumors, found some effectiveness. And so then Howard Holmesley took it through, and that became sort of the standard. The problem is it's so toxic, right? When you take bleomycin, it has effects on the lungs and causes pulmonary fibrosis. And actually 2 people died on the initial trial with BEP. Since then, we've changed, we've tweaked how we administer BEP, but it's still, even though it's sort of been the standard of care for the first line of chemotherapy, there are issues with it. And so the question was, can we find something that is just as good and less toxic? And it turns out that that is what I think you're going to see come out of 264, that really the new standard of care is going to be paclitaxel and carboplatin, because it was essentially no different in outcomes, but much less toxic, which is actually what we expected. So that's actually a huge thing. I think we're going to end up saving a lot of women toxicity with the use of paclitaxel carboplatin compared with the old standard of BEP. So that's kind of our first take home, and that's actually a huge kind of coup to get this done, because getting that research funded and supported on a national level was quite a challenge. And I have a whole lot of gray hair under here for getting that trial done. So that's for upfront advanced granulosa cell. And then we also have, in that trial, there were patients with recurrent disease who hadn't had chemotherapy before. And we see the same things there. So again, paclitaxel and carboplatin really may work very well for patients with granulosa cell tumor. There's some other things that we've looked at. You know, when I think about this, I think about, does surgery work? Yes, it does. It's different than your straightforward ovarian cancers, right? So different than high-grade serous, where we don't tend to do multiple episodes of surgery. Granulosa cell is different because it'll pop up, you know, isolated in one spot, then another spot, sometimes years in between. And so we do use surgery on multiple occasions for granulosa cell tumor, which is a different sort of scenario than we see for other types of ovarian cancers. Radiation occasionally can be useful, but really what it comes down to, I think, is much more emphasis on targeted therapies and hormonal therapies now. So that's sort of what's more new and upcoming. We showed in GOG 251 that Avastin or bevacizumab was useful in the recurrent setting, and people who respond to Avastin tend to respond for a long time, even years. And then we then saw the Alienor trial, which is a ridiculous name for a trial, and the Alienor trial in Europe combined Taxol or paclitaxel with Avastin, and we saw good results there too. So we see kind of this movement to using targeted therapies, anti-angiogenic agents there. There's some more work being done with hormonal therapy. We now really are looking at things like palbociclib, hormonal therapy like letrozole, Lupron, things like that. And this is kind of exciting news. So we had a rare tumor think tank, like a preclinical think tank just prior to the NRG meeting in July, where we brought together the rare tumor leaders, not just in clinical trials, but also in the lab. So people who have done work, and now we've brought those people together so that we're able to really think sort of at the forefront of what is new on the horizon. So I think what you'll see coming out in the next probably year or year and a half is very well thought out rare tumor studies for granulosa cell tumor, for clear cell carcinoma, and potentially for germ cell tumors as well. So there, I've spent a while on granulosal cell tumors there. So here we have someone, gosh, who with mucinous and clear cell ovarian carcinoma stage 3C, no evidence of disease since 2010. That is fantastic. So there's some thoughts about, in the question about diagnosing mucinous carcinoma and the use of immunotherapy. So let's get to those. So mucinous carcinomas are really tough to diagnose. And it's not uncommon to have a mixed carcinoma. So there are two thoughts here. One is with mucinous carcinomas, we have to be super careful about how we diagnose those. In fact, some of the studies that we've done in the past have kind of been contaminated and not actually worked very well. We had to shut one down because of inaccurate diagnosis. So pathology review by somebody who is very used to looking at complex GYN cancers, so a GYN pathologist, is really key. That's not to say that your diagnosis is incorrect. It's just to say that it's a challenge to accurately diagnose mucinous carcinomas because they can come from the ovary or the GI tract, and other places, and getting that diagnosis accurately is really important. They do sometimes these come in clumps, so you can see a mixed tumor, mixed epithelial tumor with mucinous and clear cell. So just because you have two spots in there does not mean it's inaccurate. That does happen. Immunotherapy has been used in clear cell carcinomas, not just within the ovary, but other types of clear cell carcinomas. And when it works really well for a really long time. I actually have somebody in my practice, I just cleared her for multiple years worth of nivolumab because it worked very well. She came in with a very large mass here. It's gone. So this is really amazing for patients with clear cell carcinomas, independent of where they started. So that information is not gone. That information is actually being studied in clinical trials right now. And one of the things that we find really useful now is using molecular profiling. So one of the things I think you'll see change along the way is instead of in the past where we looked under the microscope and we said, oh, this looks like a mucinous carcinoma, or this looks like a clear cell carcinoma. And then we tried one drug on that one type of tumor. That's all changing. So one of the ways that we are looking at this now is actually doing molecular profiling, almost getting the personality or the mutations that exist within a specific person's tumor and saying, okay, this patient has a PD-1 or a PD-L1 mutation. They're likely to be a really good candidate for immunotherapy. And so actually there's a trial out now that functions exactly that way. It's the Bouquet trial. And I'm actually going to plug that trial to please share this information out because it is an incredibly novel way of studying rare tumors. In the past, we've had to try and get trials open at really institutions, a handful of institutions that were committed to studying these rare tumors. And it was a problem because institutions don't want to open a trial where they're only going to accrue 2, 3, 4 patients over a number of years. With this type of platform trial, and specifically with the Bouquet trial, you can open this trial in these institutions, and the arms, in other words, the drugs that we're studying can kind of plug and play. So you have 20 patients who are going to be treated with a specific drug for a specific mutation, and then that's going to be taken out and replaced with another one when we get the answer. So it's a way that we can study lots of different potential drugs for patients who have rare tumors, and it's not just kind of random. It's not willy-nilly. It's targeted to their specific mutation based on molecular profiling. It's really cool stuff. It's a different way of studying that we think is going to be a lot more effective. So again, that's called the Bouquet trial. And it's for patients with any epithelial rare ovarian cancer. So patients with clear cell carcinoma, patients with mucinous carcinoma, patients with even like a malignant Brenner tumor. So all endometrioid, all of these patients are candidates for this trial. So let's move on here. Hello from a mucinous survivor in San Jose, California, eager to learn all about new treatment and surveillance options. So fantastic, welcome. So I mentioned a little bit about the problems with studying mucinous carcinomas, and a lot of it boils down to diagnosis. Diagnosis is really tough in mucinous carcinomas. So what we tried to do was study patients with primary mucinous ovarian carcinomas, basically mucinous cancers that started in the ovary. And we, there were 4 arms actually. So it was paclitaxel carboplatin, which of course is what we usually use to study or to treat ovarian cancers, versus more of a GI regimen. So oxaliplatin and capecitabine, and then plus or minus Avastin in each arm. And so this is a really well thought out, well-designed trial. The problem is that only a handful of the patients who went onto that study actually ended up having ovarian cancer, and most of them ended up having a GI primary. So, and that tells us that central pathology review is really important. That's really an unfortunate happening because it's hard to get the answer then to this question of, if paclitaxel carboplatin doesn't work as well as we want it to in patients with mucinous carcinomas, does a GI regimen work better? And so we don't actually know the answer to that. We don't know if oxaliplatin capecitabine works better than Taxol and carboplatin. We don't know if adding Avastin into this is going to be useful. And so unfortunately, that is an unanswered question at this point. I think in terms of, new treatments, that's again where the Bouquet trial comes in, because instead of just studying mucinous carcinomas, we're studying patients with mucinous carcinomas who have certain mutations that we can target. So like if the tumor shows KRAS mutations, we can come in with essentially an anti-KRAS, a MEK inhibitor. And so that's a totally new and different way of studying, but it's really useful. So I would say that the Bouquet trial is sort of the answer to your question in terms of what's new with mucinous carcinomas. And again, in terms of treatment, I would say it's sort of that the option of GI regimen, so oxaliplatin capecitabine plus or minus Avastin, which may be better than paclitaxel and carboplatin. In terms of surveillance, it's tough because there really aren't any studies that speak to surveillance, though we do routinely do CEA and CA-125 pelvic exam in addition to the history and physical. And then if there's anything that's abnormal in that area, then we get imaging. We don't want to overdo it with imaging because of the radiation actually that comes with the CT scan. So that's why we don't do every 3-month scans on patients for surveillance. We really use that combination of history, physical, pelvic exam, and appropriate markers like CEA and CA-125. And then if there's any abnormality there, then we go to imaging. Now the caveat to that is, if your ovaries are still in, then ultrasound is a really good way to surveil the remaining ovary. And that's important in patients of reproductive age that elected to keep an ovary present. And that's true really for any early stage ovarian cancer. So yes, and hi from Columbus, Ohio. And yeah, so next question is, during my talk this morning, I mentioned that clear cell was more easily treated when it was early stage. What stages are considered early stage? So thanks. So that's true. So patients with clear cell carcinomas of the ovary do tend to have a much better outlook, prognosis, when the clear cell carcinomas are diagnosed early. It's harder to treat and prevent recurrence in patients who have more advanced stage disease. And that's really true, for just about any cancer, not even just ovarian. Specifically, though, for clear cell carcinomas, patients who have stage 1A disease tend to do extremely well overall. There's sort of a line in the sand when we get to patients who have disease outside the pelvis. So patients who have stage 3 disease, we need to be much more aggressive about treating, because that's what we would consider advanced stage. Some would, there's been a lot of discussion about stage 2, and does stage 2 actually even really exist? I think it does. Of course, we have the staging, but the point in people saying, does stage 2 really exist, is, once the cancer sort of escapes the ovary and then escapes the pelvis, it's a different biologic activity. It works differently, and we need to be able to treat differently for a sort of contained ovarian cancer versus something that's already escaped the ovary. And so, just to directly answer your question, we consider early stage really stage 1, and then 2A and above would be a more advanced stage. It's all relative, but that helps us sort of make that dividing line. Hello from South Louisiana. Do I think that the current MEK inhibitors are less toxic than the ones used in 2013 through 15? That is a great question. So I think that we didn't have a whole lot of experience with MEK inhibitors when we started using it. We didn't know how to treat the side effects. We didn't know even, for dermatitis, how do we treat the dermatitis? Diarrhea, how do we treat the diarrhea? How do we dose reduce? All of those things. So we didn't know that then. Now we know that a lot more, and not just with the, currently available MEK inhibitors like trametinib, but we know that even, I think that information has informed how protocols that study future MEK inhibitors are written. So I think the bottom line is we just know a lot more about these tumors now, and a lot more about the agents. So it helps. I have a number of patients on MEK inhibitors now, and I find that their toxicity is almost always not just manageable, like most people on long-term MEK inhibitors really feel great, because you can manage those side effects and get them to sort of a normal life. All right, next person. I had an immature teratoma, stage 1A, but high grade, so did chemo. That's so recommended. Such a great question, and the answer is, that's a terrible answer, right? But this is one of the areas where we are looking to minimize our treatment. And so with germ cell tumors, specifically like immature teratomas, dysgerminomas, we really are looking to minimize the treatment. Currently, so the high grade is the key there. And if there is a component of yolk sac tumor there, then absolutely we would still treat. There is a movement away, though, from treating stage 1, even high-grade immature teratomas. And we're actually trying to follow those patients to make sure that, that we're not hurting anyone by withholding treatment. Remember how I said that BEP has a lot of toxicity, right? The bleomycin with the lungs, the etoposide with secondary malignancies, the cisplatin with neuropathy and kidney issues. So we don't want to expose people to these treatments if we can help it. And so since germ cell tumors are different than other kinds of ovarian cancer, we can pretty much cure people. The 15% of people who recur, we can cure. So that's why we're trying to walk it back and not treat as many patients. So, I don't know what made your tumor high grade. Was it yolk sac tumor or was it something else? If it was yolk sac tumor, we still would have treated you. If it were something else, we probably now would hold off. Has anyone ever figured out why clear cell is more prevalent in Asian populations? No, I wish I knew. We know it has to be something from either a genetic or like inherited germline mutation, or something in the epigenetic makeup, that changes this. We've never been able to determine that, to the best of my knowledge. And actually, we've partnered with the folks in Asia to look for differences. So, in fact, one of the GOG trials that we did not long ago, we had a component of Asian patients and a component of U.S. patients, and we stratified the trial so that we could compare. We saw no difference in outcomes, and the real key is going to be doing the molecular profiling of these patients and seeing if we can, sort out the answer to that question. But as of now, work to be done. So yes, that's a really important question that we need to answer. Hello from Kentucky. That's where I was born and spent my life, and that's where my daughter lives now. So hello from Kentucky. Adult granulosa cell tumor. I hope you're doing really well. Anything new for carcinosarcoma? So the big thing for carcinosarcomas, I guess a couple thoughts there. One is that with carcinosarcomas, we really think that these are actually epithelial tumors. And when they come from the ovary, again, they're eligible for the bouquet trial based on molecular profiling. So there's a theme here. This is the research study to look at for rare ovarian tumors, rare epithelial ovarian tumors. And so, we do know more about carcinosarcomas of the uterus now. Matt Powell finished that trial, I think just about a year ago now, which really showed that paclitaxel carboplatin was essentially equivalent or better than, and with fewer side effects than, the more toxic ifosfamide platinum. And so that's a real benefit for patients with uterine carcinosarcomas. The other thing, one of my colleagues here in Ukraine is spending time looking at MMMTs or carcinosarcomas of the uterus from a molecular standpoint. And we've worked with one of the molecular profiling companies to drill down our mutation frequently, with carcinosarcomas, either of the uterus and either carcinosarcomas of ovary. There's no sort of specific mutation that is specific to carcinosarcoma. So there's nothing that we can say, okay, for every carcinosarcoma, this is a mutation that we should try. However, we do find, and I think this is an important thing, there are actually a lot of different targetable mutations in every type of ovarian tumor. And so I looked at that with the folks at one of the molecular companies, Caris, and they were kind enough to supply us with the data on, a ton of rare ovarian tumors. And we're looking at that again, updating those data. The idea is, though, that not every clear cell carcinoma is the same, not every granulosa cell is the same, and certainly not every carcinosarcoma is the same, but there are targetable mutations in each of those. We just can't tell without looking what those targetable mutations are. Let's see. Moving down the list here. So should low-grade survivors switch from anastrozole or Arimidex to a MEK inhibitor, as I discussed? If something's working, don't switch. So that is like the number one rule. So it's when we get some new piece of information, it's really exciting. And we say, oh my gosh, here's a new medication or hormone or intervention for many patients with a certain type of cancer. The thing is that it is gold when you find something that works for you, right? So if something's working for your tumor, don't give that up in the search for something, better that don't know if it's going to work at all. So I was diagnosed with granulosa cell tumor stage 1, so surgery was the treatment. That's right. I was told that genetic testing was not needed for my daughters. Is that accurate? So there's a short answer and a longer answer. The short answer is generally that's accurate. I don't know your detailed family history. So, of course, we would look at your detailed family history and see if there were other things in your history that would prompt genetic counseling and genetic testing. We looked at to see if there were inherited, like germline mutations in patients with granulosa cell tumor, and we've come up with 2 sets of first-degree relatives who had granulosa cell tumors. But out of all the granulosa cell tumors, there are just those 2 sets. I've never learned of any others. That's not to say that there might not be, but it's not enough to establish any kind of genetic linkage overall. We know that FOXL2 mutations are essentially pathognomonic. They're the cause of granulosa cell tumors, which is really amazing, actually, that we know that. But that's somatic. In other words, that happens in the tumor. That's not an inherited kind of thing. So at this point, we really don't recommend, in the absence of anything else, we don't recommend genetic testing just off the bat for anybody with granulosa cells. That's different than every other kind of ovarian cancer. So if you have an epithelial ovarian cancer, like a high-grade serous ovarian cancer, even a low-grade serous ovarian cancer, you should absolutely have germline testing. So I hope that helps answer that. Um, 10-year survivor, yay, with granulosa cell, ER negative, PR positive, AR positive, done chemo, umpteen different drugs. I know, I'm sorry that happens. Radiation, 11 surgeries, 2 clinical trials. Haven't found anything yet that works other than surgery and radiation. Yeah, boy, everybody's different. I'm sorry you've had that journey. Unfortunately, it's all too common for women with granulosa cell tumors. And so I think that's why it's so important to keep plugging away at this. Okay, I'm just going to say, I think that there is a huge future to study granulosa cell tumors. So, and that's honestly why we've started this sort of rare tumor silo within the NRG of looking at granulosa cell tumors and really combining the basic science, the translational science, with informing clinical trial development. Because they have to go hand in hand, and we're learning more and more. I think there's a lot of opportunity using new technology like CRISPR, actually, to go in. We know what the mutation is in these cancers, right? So I actually wrote a way to one of the Nobel Prize winners from a couple of years ago who developed CRISPR, because I think there might be some utility in studying that. Anyway, I think we're going to see a lot of changes in the future, but it's going to take this kind of coordinated effort. And that's why I'm really excited about what's happening, because we have people from literally all over the world coming together to look at these things. And yes, I so appreciate your comment that if you haven't joined already, please join the Facebook group GCT Survivor Sisters with 1,700 women worldwide. Can I join that? Is that okay? I would love to join that. So I'll put my name there, and hopefully somebody will accept. But I asked my oncologist about getting genetic testing as a stage 2B ovarian cancer survivor as low-grade, borderline, told that yours was because of hormone issues, not genetic. So low-grade, I think it's very unusual to find inherited mutations, but it's not a never. So I feel like, yeah, I would talk with your oncologist about it. It never hurts to talk with a genetic counselor, and again, to put your family history in there as well. Germline testing is pretty straightforward now, easy to do, and so for low grades, I would be more enthusiastic about that, to be honest. And it's very unusual that it would be genetic, big and not zero. Any studies planned for granulocyte tumor hormonal therapy? Yes, there's actually one. I think it's an androgen receptor study that's ongoing at Memorial Sloan Kettering right now. But there are definitely others that are coming through. There's one that's coming through, working its way through NRG right now. And so I would look to see that open, you never know, hopefully within 6 months. Don't quote me on that one because I'm not responsible for those decisions. I'm on letrozole up to 2 more years or extend up to 5 more years. Boy, I would need to know more about that, about your details there. And those are very specific sort of patient-related questions, so I think it's hard to, without knowing somebody's entire history, to sort of say one way or the other a timeline. So I'm going to hold off on weighing in for that. ctDNA for treatment guidance. When do you think this will become common practice? That is a great question. So, am I going in and out? I'm so sorry. Is it better now? I see people saying yes. Okay, good. Sorry if I was breaking up there. Let's see. Okay, ctDNA. So this stands for circulating tumor DNA, and what a really cool technology this is. So basically, through a blood test, there are companies out there that will look for little fragments of DNA that's coming from the tumor. So right now, what that's approved for is following patients on immunotherapy. Because the question becomes, sometimes this, immunotherapy works so well. I mentioned my patient who has a clear cell carcinoma who has no evidence of disease after years of nivolumab. So what do I do with that? What does she do with that? Do we stay on this just sort of indefinitely? Do we stop? How do we know? Do we risk if we stop? Is the tumor going to grow back? I mean, these are the questions that we all face, right? So one potential for this, and we know it works in colorectal carcinoma, is you can look for the circulating tumor DNA, and if it's absent, that gives you evidence that you can stop. If it's present, it tells you you need to continue. So that actually has been FDA approved for patients with colorectal cancer on immunotherapy, and now it has been approved for all patients receiving immunotherapy regardless of their tumor site. So basically, if an ovarian cancer patient is on immunotherapy, you can get this test done, and it's covered cost-wise. This is really great news. We are actually looking to see, is this, how useful is this technology in other areas? And so we have an investigator-initiated trial that's going in to start very soon so that we can offer this to our patients, we can follow them, and we can see what happens and see in GYN cancers, is it useful? So I will say some of these companies who are doing this will actually very much work with you. So I would talk with your oncologist about that because you can send off, the vial of blood, do the test, and gain information. And a lot of times it won't break the bank. We don't know how useful that information is now, but so if I didn't get to your question, could I ask you to enter your chat in there? Answer, yeah, here we go.
Dr. Brown, is your camera on? We can't see you, or at least I can't see you. Can the rest of you see her? Oh, there she is. Maybe it was just me.
Better now?
Never mind.
Okay. That's okay, no worries. I'm glad you mentioned it. So, great. Okay, so currently FOXL2 is not a targetable mutation for granulocyte cell tumor. Is it a mutation that is just not targetable, or is it that we haven't figured out how to target it yet? I'm banking on we haven't figured out how to target it yet. We don't have anything that that reaches that mutation, and it's a very specific point mutation. So, fingers crossed that we will be able to work on that and make some progress there. So here is all the questions are coming through. Okay. Yeah, letrozole causing joint pain. It's so tough. Yeah, letrozole really does cause a lot of joint pain for a lot of people. I've had a couple people who just simply couldn't tolerate it. So I think it's reasonable to try other types of hormone blockers, if you will. You know, there are a number of different inhibitors out there, and I think it's reasonable to try, if you've had good response to letrozole, to try almost like another version of a hormonal inhibitor. A lot of discrepancy on what markers to monitor for adult granulosa cell tumor. There, yes, you're correct. I actually usually do a panel of 4 on my patients, inhibin B, inhibin A, which we know from the GOG 251 data, inhibin A is not usually as good as inhibin B, or it's not as specific or predictive. However, you know, if it is a marker for you, then it's a marker for you. Everybody has a different tumor type, right? So inhibin B, though, in general, tends to be more reflective. AMH, which is anti-Müllerian hormone, also can be very useful. And CA125 occasionally can be useful. So I feel like when you're starting out, that panel of 4 is the panel that I use. So inhibin A, inhibin B, AMH, and CA125. However, what sometimes we find is that a specific marker like a inhibin B might be really useful for a given person, and so then that's what we can follow. Great. Here's a patient with stage 3C primary peritoneal carcinoma with recurrence 11 months after debulking, only being offered letrozole. I would honestly need to know way more about your situation to weigh in on that. You know, I would say that if you're seeing a board certified GYN oncologist, that you can ask them questions about your situation and have them share the reasoning why they're making that recommendation. And I would ask for other recommendations as well. And if you're not satisfied with the answer, and I tell my patients this too, it's okay to get a second opinion. There are a lot of places around that would certainly offer a second opinion. That may absolutely be the appropriate treatment. Certainly if it's like a low-grade situation, then that may be why they're making that recommendation, in which case I would absolutely agree. But there may be a lot more to the story, and I just don't know the answer to that. Yeah, okay. So here's someone with, Carla, with stage 3C mucinous carcinoma. Have had genetic testing for 7 cancers in the family, including pancreatic. Oh my gosh. The panels came back clear with no mutations for anything, including BRCA. But now there's a question of, can mucinous be related to pancreatic, and should there be blood tests? So it's complicated. All this stuff is complicated, right? And I'm sorry for everything that you've experienced. And when I hear about family history like yours, it does make me think that the genetic testing that we've done, it's not really negative, it's just not informative. So I would call that an uninformative negative, right? Because we know there's something going on in your family, right? And until we can find the gene that's responsible for that, it's just that we don't know what we're looking for, right? So, you know, I don't know that there is a good recommendation in terms of a specific blood test for you monitoring for pancreatic cancer, but the way that I would, with your family history of pancreatic cancer and your specific mucinous carcinoma, I mean, I'd probably be looking at pancreatic surveillance as well. And I'd talk with your oncologist about that. Just kind of remind them of your really extensive family history and see what they would recommend for pancreatic surveillance. Much like someone with a BRCA mutation who needs pancreatic surveillance, you may sort of fall into that category as well, given your family history. So this is a great sort of general question. Is there any consensus of how long to stay on a given treatment that's working? So if you have no evidence of disease for X amount of time, can you come off? And this gets to that question of sometimes we don't know if immunotherapy is working, how long do you need to stay on it? All your imaging is negative, your exam is negative, your markers are negative. So generally speaking, we say for most immunotherapy 2 years past no evidence of disease, but not everybody is really happy coming off. You know, sometimes it takes a while to get a response. And this is where ctDNA for immunotherapy, that circulating tumor DNA, may play a good role. So hopefully that answers the question. Many doctors don't believe AMH is a marker for granulosa cell tumor. Is there an article I can recommend that I can share with the Facebook group for women to take to their gen-oncs? I think it's actually made it into guidelines now. And I would ask, you know what, you've got, I'll just make a note. And if it's okay with you, if I can join your Facebook group and just share that out, I'm happy to do so. Yeah. So the panel was first for 25 mutations, and 10 years later they had added another 120 for those 7 cancers. So this is a good point to make for genetic testing really across the board. So, you know, back in the day, we would test just for BRCA1 and BRCA2, sometimes just the founder mutations that we knew about, right? Well, wow, has life changed. Now we know so much more about inherited or inheritable mutations, right? So the panels that we send are very different. And so, you know, we'll see many more mutations that we can identify that matter. And these panels change all the time, actually. Many of you may know that the genetic testing companies actually feed into a national database of mutations and patients that are linked with outcomes. So it is a dynamic situation. It is literally continually being updated. So people sometimes will get a VUS on their testing report, so a variant of undetermined significance. Basically, it's a mutation that pops up and the genetic testing company says, well, we don't know what this means. Most of those things are benign. Most of them are not associated with any increased cancer risk. But what it means is this is one that we're going to look at. This is one where we're just collecting data, and along the way, chances are it's going to turn into a nothing, right? It's going to mean nothing and not be associated with any increased risk. But occasionally, those variants will be reclassified as something that does imply a higher risk. And so, you know, when that happens, typically the genetic testing company will inform you of that because it matters for you and for your family. So yes, these tests are different. I would say if someone has had if you've had a germline test done, a genetic test done 10, 15 years ago, you might want to think about getting it repeated because it may have more information now that just wasn't available that long ago. We have time, we've got like 6 more minutes. Let's see here. Oh, yay, great. So I can join Granulosa Cell Tumor Warriors. I'll do it. So let's see. So it's really great. We have so many people here who are granulosa cell tumor survivors. That's fantastic. I'm glad for all of you. That's really just wonderful. April, you're a nearly 10-year granulosa cell tumor survivor. Congratulations, with several recurrences. Currently on Avastin and fulvestrant, waiting on results from the most recent MRI done last night. I'll be thinking of you. That's fantastic. Seems stable, but the blood work is all over the place. Yes. So this happens all the time. So it's a little different with granulosa cell tumor that like an inhibin or AMH than say high-grade serous carcinoma is for a CA-125, right? In other words, CA-125 for many people, most people, tends to correlate a lot better with what's going on with cancer. And the reason is hormonal. So a whole lot of things that go on in your body will change inhibin levels, whether it's inhibin A, inhibin B, AMH. Those levels tend to fluctuate pretty substantially. And that's true before menopause. That's true even after menopause. That's true with your ovaries in or out. And it's true independent of sort of granulosa cell tumor. But what we can look for is trends. And like with anything else, this is really hard to, it's hard to wrap your head around, right? And it's hard to live in it. But a number's just a number, right? Lots of things can cause those things to fluctuate, and they cause a lot of anxiety as we're looking at them and trying to sort out what's causing those fluctuations. But the bottom line is the tumor burden, right? So if your scans, whether it's an MR or a CT or a PET, if the scans show that your cancer is decreasing, doesn't matter what your number is doing, the proof is in the pudding. The proof is in that CT, MRI, or PET. Let's see. If you have a KRAS mutation and are ER positive, which deficiency might you focus on? So I would say that for any molecular profiling result that we get, so if you find a mutation in KRAS, that's really honestly great news, because then you have that as a target. If you see that your tumor is estrogen receptor positive, then that's great, because you have that as a target. And I think these things, it's not like there's one that's better than the other. I'm gonna assume that you're talking about maybe a granulosa cell tumor. I don't know, but regardless, that gives you really two options for an intervention. And there, I would talk with your oncologist about. There's so many details in terms of the specifics of each person's cancer, but it may be that estrogen antagonist would be more useful. It really kind of depends on the track record within that specific tumor type. I think the good news is it gives you two good targeted options that are personalized for you and your cancer. So. Yeah, and here's April says that she gets a panel after hysterectomy and it's hard to track since on Avastin. And I think it's true. These panels are hard to track. Honestly, whether you're on Avastin or other chemotherapy, or even if you're just following, even if you have no evidence of disease, they do just fluctuate a lot, and that's really frustrating because we all kind of want to hang our hat on a number, and it kind of like we talked about, it's tough to do. So I think we're down to time. I've got probably 30 seconds. I want to thank each of you so very much, really for your passion and your dedication. It's 6:30 at night and you guys are still here and totally engaged, and I just really appreciate you. This is just such a great group. Thanks for your support and your interest, and hopefully we're going to make some major changes and advances in rare tumor research in the future. Thanks so much. Oh, and real quick, one more thing. You can email me if you have questions or you want to talk further. Always happy to engage. Okay, bye.